record on this. Oh, official. Hello, this is Professor Bites, Thursday, March 21st, and we are doing module 7, which is on schizophrenia, which is a very complex, complicated diagnosis that we'll do our best to flesh out. I always like to give the disclaimer. This is so far from my specialty that I know just enough to be slightly effective and knowledgeable. But it's just such a complex disorder. So if we're 5 slides in and it's like, that's really complex, that's confusing, probably slide 15 might also be that way. And so we'll kind of walk through that, but I'm using that abbreviated PowerPoint that's been trimmed down. So we'll open it here. And all right, so, we start with a second slide. What is it? Schizo, meaning split, phrenia, meaning mind. So of the split mind. And this split's going to occur between a person's thought process and actual reality. Now, reality being a subjective term, right? We all have different definitions of reality. So this is, again, where the DSM, we kind of stick in a box, and those of us as social workers look a little bit outside the box, which we'll talk about. And then schizophrenia, a definition. So most generally characterized by distortions in thinking, our perceptions, our emotions, our language, sense of self, and how all of this could potentially influence our behavior. Most commonly, what we've heard over the years, hearing voices and illusions. So worldwide, as we know, schizophrenia, if you didn't know, schizophrenia is associated with considerable disability because most likely, if left untreated, could affect educational, occupational, and also relationships. So individuals with schizophrenia are 2 to 2.5 times more likely to die early than the general population. And this is including oftentimes due to physical illness, cardiovascular, metabolic, and infectious diseases. Stigma, discrimination, and violation of human rights of individuals with schizophrenia is common. Okay, so again, I don't know if Katie Veit can work here. A little bit of erratic behavior. It's not really effective anybody. Job loss, no insurance, but just kind of that, are they a danger to somebody else or themselves? That's more of the extreme kind. But just the stigma around, I think also with schizophrenia is it is so complex. So many different criteria that when you read it, it's like, oh my God, that is a beast. There's so much to consider. It's so big. But we know with treatment, it's treatable. And that's typically through medicine and psychosocial supports is what makes the treatment and outcome most successful. So schizophrenia, a definition. So common experiences, we know delusions, so really know the definition of delusions, which is a fixed beliefs that are not amenable to change in light of conflicting evidence. Okay. Possible themes, referential, somatic, maybe religious or spiritual, but a fixed belief, that oftentimes is not related or have a baseline of truth. Hallucinations, perception-like experiences that occur within an external stimuli. So vivid and clear, the full force and impact of normal perception and not under voluntary control, okay? Disorganized speech, a formal thought disorder, includes the derailment or loose association, tangentiality, incoherence, or word salad. So that could be just mixing up words, kind of interrupted thought, not incomplete sentences. Again, not going to be like, oh, that's schizophrenia. but going to be kind of under the umbrella of what we're looking for to formulate a diagnosis. Grossly disorganized or abnormal motor behavior, including catatonia, okay? So taking issue with goal-directed behavior. Catatonia meaning, someone disassociating, they've stopped talking, they've kind of froze, are no longer responding. Is that disassociation due to talking about something, or have they slipped into a catatonic state where auditorily and visually they cannot respond? And they can sit there with their eyes open, looking straight forward for a hot minute, okay, without responding to any stimuli or direction. The definition continued. So the disorganized, we've already talked about that. So what we're going to skip to on that slide is where it says negative symptoms. This is how we classify. So under negative symptoms, the decrease of emotional expression, including reduction in expressions in the face, eye contact, your speech, and movement of possible head or hand, face, that give an emotional emphasis to the speech, maybe grimacing. We're going to talk more about what that looks like. Avolition is a decrease in motivational self-initiated purposeful activities. And then we have anhedonia, asociality, and alogia. All of those are related with speech, the word salad, word comprehension, word displacement. Those are the negative symptoms. So here we go with the positive, the negative, and secondary symptoms of schizophrenia. Positive, hallucinations, delusions, thought disturbances. Negative, more of the speech, facial expression, conversation. Secondary, okay, another classification, depression, okay, loss of employment, breakdown of relationships. So comorbid with schizophrenia could be depression, maybe even anxiety, most common depression. And comorbid could be job loss due to positive or negative symptoms, and just an overall breakdown of relationships, right? If you start changing, acting differently, and you're paranoid, talk a little bit more. Sometimes relationships can, be harder to maintain because sometimes people are like, I don't really know what to do with that. You don't seem to want to change. You don't find this disturbing. You might not want to be there for it, right? And that's that relational component that perhaps can lead into depression if you are fired, your partner, spouse, relatives are like, we don't know what to do with it, and depression can set in. So while the negative symptoms are less dramatic, they tend to last longer than the positive symptoms. And less dramatic being less pronounced, okay? So if somebody is kind of having word salad or has trouble kind of completing a thought, that's way different than having a hallucination. So that could be going on for a hot minute, but if it's not going to be a severe threat to oneself or somebody else, or there's no paranoia, with it, it can kind of just go on undetected. Evaluation. Positive symptoms. So again, hallucinations, delusions can be affected by cultural differences. Okay. So that's where us social workers say, have you considered if this is a cultural response or behavior? Is this a spiritual response? If somebody is speaking in tongues and you've never really heard of that and they're just screaming and it's in a different language, are they delusional? Is this some sort of ceremony like voodoo, where you're sometimes ridding a spirit or getting rid of a feeling, and people can shake, stop talking, scream. So it can be hard to measure objectively. And again, negative ones can start before the positive ones. And like we kind of piggyback, could start years before the diagnosis. And these negative symptoms are going to be less affected by cultural factors and more objectively measured. Okay, so it's all right, you have not had any interruption of speech or facial movement or anything, and all of a sudden you have that. You can oftentimes see that, and then you can start ruling out, is that a medical condition? And we'll be talking about that as well. So the illness has three different phases. So the 1/3 of the first phase, the individual becomes withdrawn and could lose interest in work, school, or leisure activities. Okay. Another third phase, or third part of the process, is the active phase. More obvious symptoms start to occur. The duration can vary per individual. Some people, it could last a few months and then we introduce treatment, whereas others remain in the active phase if they are unable to access treatment or refuse treatment. Okay. Okay, well, I'll come back to that. But the residual phase, the obvious symptoms begin to subside. Again, this typically is with intervention, and we're going to see that pharmacologically, that's usually the first intervention. Okay. So again, it's really hard to argue your case that a person is delusional when they are delusional, because what they hear, see, feel, think feels extremely real to them. So it can be really hard to be like, Alyssa, what you just said, oh man, on the cuckoo spectrum, we're a little cuckoo sided, no, it's real. I'm really scared. You should be scared too. You've been reading, yes, been reading, and so that's the hard part for any caregivers, loved ones, spouses, is like, they don't believe me and I don't know how to get through to them. The severity of the symptoms, wanting to die by suicide, do something pretty catastrophic, obviously homicidal, are typically what is the involuntary hospitalization. Okay. We'll be talking more about that. Prognosis. It's the rule of the thirds. Okay. Third recover more or less completely. Third have like episodic impairment, where they experience different episodes along the way. And then a third, most likely untreated, just have that chronic decline, where then it's considered no longer acute, but a chronic mental illness. We know this is, it looks better than 40%. 60% of patients manage a relatively normal life. I think the word normal is a little bit subjective, but going back to what their baseline of functioning was. They're back to work. Their family has taken them back in. They're maintaining relationships, that kind of thing. That was their norm of functioning before the episodes began to occur. Prognosis is better in non-industrialized societies. There's less pressure to have a job, right? In our culture, we take care of our own. If you don't need a job, we will help you. Okay. So if you're not at risk to somebody else and we don't believe in the treatment, but you don't need to go back to work, we'll help you parent your kids. Then that could be, maintained in that type of setting. All right. Types of schizophrenia spectrum disorders. We're going to be looking at all of these. We're just going to keep on moving through. Epidemiology of schizophrenia, top of the slide, suicide. Okay, 10 to 15% of individuals with schizophrenia die by suicide. 50% attempt suicide. Most common risk factors: male, young, maybe a post-psychotic depression, realistic assessment of deterioration due to the illness. Okay, I can't live like this any longer. I believe I'm not worthy of living, so I attempt, to take my own life. It could happen within an episodic type situation, or if you are taking antipsychotic medication, you have joint pain, you're nauseated, you have headaches, but you don't present with schizophrenic symptoms. Okay. Well, when I was presenting with symptoms, I didn't find it too bad because I didn't know what maybe I was saying. And now I know I'm not having any delusions or what people are telling me I used to have, but I'm sick to my stomach. I've got joint pain. I can't go to work because I feel sick all day. I might be numb, all the things that it's like, okay, I don't like either side, of being treated or untreated, that hopeless, helpless feeling. You have to always consider, and this is going to be a common thread, substance use. Cigarette smoking. Interesting fact here, 75% of individuals smoke. There may be brain abnormalities and nicotine receptors in schizophrenia. Increases the metabolism of some of the antipsychotics. Okay. Nicotine appears to improve some cognitive impairments. Okay. And it could decrease positive symptoms. So if you hear of like a higher percentage of individuals who are schizophrenic that smoke, this could be why. Maybe it was suggested, who knows? But that correlates with kind of, I don't know if better prognosis or outcome is accurate, but metabolizing, increasing the metabolism of antipsychotics is a good thing. Okay, alcohol. Okay, 30% of those with schizophrenia are going to meet criteria for the diagnosis of substance use disorder. Cannabis and cocaine are two other commonly used drugs. High cannabis use increases the risk of developing schizophrenia by 6 times. Okay. And alcohol and drug use are associated with a poor prognosis. Well, if it's affecting your antipsychotic or if you're having a substance use hallucination or delusion, that substance is just getting in the way of successful treatment. Okay. So oftentimes individuals are asked to refrain from substances, and that might mean getting the schizophrenia under control. Okay. And then going for substance use treatment. Socioeconomic and cultural factors, unlike non-industrialized nations, a disproportionate number of individuals are in the low socioeconomic groups or communities. A downward drift hypothesis versus that social cause hypothesis. Recent immigrants have a higher rate, suggesting the tremendous amount of stress of abrupt culture change as a risk. We don't take a lot of time to help somebody assimilate. Perhaps they don't have access to their children right now, access to services. They're not sleeping, they're not eating. Their system's going to change, how they perceive things. Possible paranoia. We don't speak the language. We've been told to hurry. All the things that kind of can increase some of the symptoms of what would present as schizophrenia. Population density, prevalence rises with the increasing density in cities greater than 1 million. It's not, when we're trying to explain it, it's not a single disease, okay, but it's a group of disorders with heterogeneous causes, okay? Back, I think it was the first class, we talked about the diathesis stress model. The person has a specific vulnerability, diathesis, that when acted on by stress leads to the development of schizophrenia. The stress can be environmental or biological or both. Increased amounts of stress. So again, it's like, well, we're all going to have likely little bouts of stress, but we're talking just more and more stress, impairment on the brain, maybe crisis, trauma, what have you. Genetic factors, we know that there are significant genetic factors contributing to some, perhaps all, forms of schizophrenia involving multiple genes, okay? Paternal age, I thought this was really interesting, a direct correlation of increased risk with advanced paternal age, Okay, so that has to do with perhaps older swimmers, older sperm, and older men who are having their sperm put into somebody. I'm going to have to hit edit. Makes no sense. But it's going to affect genetically the predisposition or disposition of. So, it's, I mean, I think when you're gathering history, it's like, do you know of anybody in your family that has schizophrenia? No, we don't really talk about it. Okay, well, back then we didn't call it schizophrenia. You'd be out of your mind, you'd be sent away for 6 months. Perhaps it was a lobotomy. Perhaps it was electric shock therapy, which looks different nowadays. And, you had a baby, you went cuckoo, they put you on some Valium, got sent away to stabilize. That's now postpartum psychosis, things like that. So it's like, okay, well, if you've heard about that in your family, chances are there's going to be some genetic component. Even if we don't know what schizophrenia, we know Uncle so-and-so used to be real paranoid and pace all the time, thought everybody's out to get them. That doesn't mean you should not have a child, okay? That just means you're aware of the genetic influence, okay, that comes with having it run in your family, okay? That means that perhaps, like with other disorders, you might be on the lookout. And as we know, proactive intervention, early intervention, is going to have a higher level of successful outcome. Psychosocial factors. Many theories over the years blame the family system, especially the mom, for the development of schizophrenia. These have been largely discredited. Just because this mom had this baby in utero for 10 months does not mean she is responsible for the schizophrenia. She did nothing wrong. Okay, what happened when they were in utero? Or what did you eat or drink or do? Or did you have a trauma? No, okay, we have debunked that myth, okay? But we didn't know, right? We didn't know that the sperm could cause it. Let's examine the sperm. You got old sperm. Take that into accountability here. It's been shown that individuals living with parents or caretakers with high levels of expressed emotion, criticism, hostility, over-involvement have high relapse rates. Okay, so again, looking at every move someone makes, kind of being on edge, can make someone paranoid, right? Over involvement, kind of controlling every little thing, excessive worry, can make somebody kind of, get a little rattled. The DSM-4 TR and the DSM-5 TR, diagnostic criteria for schizophrenia, criteria A through F must all be met. Okay, A through F must all be met. Okay, so here we go right out of the gate with characteristic symptoms. 2 or more of the following, each present for a significant portion of time during a 1-month period. Okay, or less if successfully treated. So here we have, the big 5 here. We're looking at all of those. So again, 2 or more of the following. Note, okay, only one criterion A symptom is required if delusions are bizarre or hallucinations consist of a voice that keeps running, a constant commentary on the person's behaviors or thoughts, okay? Or a person hears 2 or more voices conversing with one another. You maybe go to sleep and the voices stop talking, but once you wake up, you got a little dialogue in your mind and you're not part of it. If you are part of it, that'd mean not schizophrenic, but if we've got multiple people influencing our behavior and thoughts, kind of up the game a little bit. Criteria B, social occupational dysfunction. Okay, so we're looking at, again, like all disorders, this is when we get in the weeds because we're counting on someone kind of recounting a timeline. So we see things like for a significant portion of time since the onset of the disturbance, one or more of the major areas of functioning. So here we go with the work, interpersonal, self-care, are below the level achieved prior to the onset. Okay, so this is not, 6 weeks ago, this was not how we were presenting at all. Okay, this is a major change in presentation. Okay. Again, how long has this happened? Criteria C, the duration. Okay. Continuous signs of the disturbance persist for at least 6 months. Okay. The 6-month period must include at least 1 month of symptoms. So here we are being like, has it been at least a month? I don't know how long it's been. Okay, that's okay. We're going to just try to come up with some examples, or has anybody said this for a long time? And again, during these prodromal or residual periods, the signs of the disturbance may be manifested by only negative symptoms. Okay, those negative symptoms here, or 2 or more symptoms listed in criteria A, presented in attenuated form. Okay, those odd beliefs, maybe an unusual perceptual experience. Criteria D, schizophrenia diagnosis. Okay, we're going to learn more about schizoaffective, but here we see it popping up. We're excluding schizoaffective and mood disorder. Okay, so schizoaffective disorder and mood disorder with psychotic features, those have been ruled out. Okay, because we do not have a report of a major depressive or manic or mixed episode. Okay, or hypomanic have occurred concurrently with the active phase symptoms. Okay, so remember that active phase was that middle phase. Or if mood episodes have occurred during active phase symptoms, their total duration has been brief relative to the duration of the active and residual periods. That was a big old mouthful. It's like, or what if, don't get lost in the weeds. None of this can be memorized. We're just familiarizing ourselves, because chances are if we're doing the assessment, we're going down something that's helping us rule in, rule out, switch gears. Criteria E. So substance, general medical conditions we're ruling out. Drug abuse, medication, or a general medical condition. So I learned this and I had no idea of it. So example of a general medical condition would be in older adults when they have a UTI. Can really obviously be painful. Yeah, it can cause a lot of confusion, delirium, possible aggression. And it's like, oh my gosh, yesterday, Miss so-and-so is happy as a clam. Today, we don't know where we are. This was on a gradual decline. We are angry. We're paranoid. Every time that would happen, the nurse would be like, well, check for UTI. What? And typically within 2 days of antibiotics and treatment, those symptoms go away. That meant it was delirium versus like delusions. And so there's a difference in delirium and delusions, but it can present like delusional behavior. Criteria F, relationship to a pervasive developmental disorder. If there's a history of autistic disorder or another pervasive developmental disorder, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are also present for at least a month. Okay. It could be, as we've learned with, autism spectrum disorder, perhaps the way somebody communicates, maybe rapid speech, perhaps chaotic speech, facial muscle control. Well, if they have a diagnosis of autism, those symptoms, it would be, has that always accompanied the autistic diagnosis? Yes. Okay. Then we are looking at if they're being present, hallucination or delusions in order to create or start our path towards the diagnosis of schizophrenia. Here on slide 26, take a gander of that tonight on your own. It's a case study. about a 25-year-old man, and what's going on with him. Take a gander, take a look-see later. So when we look at good prognosis, here is some of the factors on this slide that contribute to a good prognosis or good outcome. You know, again, we know the family history, so we can be on the lookout. We have a good support system that's going to be on the lookout or support us through the diagnosis or treatment. And you have positive symptoms that present that are quite noticeable, right? So it's like that is a marked, noticeable behavior thought process. And again, just that overall being observed by individuals that are going to notice the change, help you, work with you, highlight it. And again, sometimes by way of you go to the hospital, you've just said something that's very scary, so we know that's not you. That's a very marked state that statement's just not ever, come out of your mouth before, or you've never ever had two voices in your mind, kind of going back and forth, contemplating ending the world. So typically, boom, it's like, whoa, hello. Poor prognosis, just a young onset, typically like obviously not treated. If there are no precipitating factors, perhaps a little bit more withdrawn due to autistic behavior. It'd be hard to kind of notice. Is it just like autocentric behavior, or is it this kind of ruling out? Single, divorced, widowed, nothing wrong with that. But perhaps someone was partnering with you that, knew you really well. And all of a sudden you are no longer with that individual, which means a reduction in immediate support systems if you're living with somebody. Also, just lack of community support, sports, and then support systems. Sports has nothing to do with it. Don't get sidelined. All right, here we go. Again, not going to read all of these, but other symptoms of a poor prognosis when comes to schizophrenia. Comes to relapse, okay? Maybe we stop taking our medication very abruptly. Maybe we think we can come off the medication and we do it slowly. We've relapsed. We're back to square one. We are back to hearing those two voices in our head converse now with a third voice. Whoa, 6 months ago, this was not happening. Has anything changed with your medication or treatment plan? Because we were doing okay, and now, bam, here we are again. Psychological testing. So schizophrenia is a brain disease that disrupts the normal, or what is said to be baseline normal functioning of many cognitive abilities. Okay, so again, that normal this is how I was, kind of bopping through life, what I was doing. Now this is an interruption to all of that. Vigilance, memory, and concept formation are most affected and consistent with frontal lobe cortical defects, okay? And then again, the impairments of attention, retention, problem-solving abilities, goal-directed behavior. The mental status exam. Okay, so in the first lecture, we didn't go through this because it's, we've got a lot. So just all the different things. When someone comes in, let's say inpatient, we may have different forms of evaluation. It might just be, we're just looking at overall, looking at appearance, maybe motor behavior. The family is like, we do not have poor hygiene. They will not shower. They will not bathe. We're not brushing our teeth. We don't care. We stink, right? People are saying you need to bathe. I don't care, right? That was not how you overall presented. Okay, let's mark that. Motor behavior, that psychomotor agitation, or lack thereof, and then looking for medication side effects that could be causing maybe like a tic, so just kind of noting any of it. Mood, mental status exam continued, just the report of the mood, Okay, so again, we're asking the individual, is it going to be an accurate report? We hope so, but sometimes we become delusional. We don't know, right? What was 5 days ago? The affect of an individual. How are they presenting in just an overall affect and response? Again, if they were not someone that was really tearful in response to questions or what have you, or they did not talk with, using inappropriate language or that type of thing. This is just really a different person. That was not how they were 5 weeks ago. Then again, the speech. One was the elevated volume. They can hear themselves yesterday. We are yelling today, and we do not notice that we are yelling. We cannot hear any difference than in this tone or this rhythm. And that's not how we presented yesterday. The perceptual disturbances or hallucinations. So here in the mental status exam, we're going to take it up a level. Most common is auditorial, okay? Frequently derogatory. These two voices in my head are telling me I don't need to be here, or they don't need to be here, or something bad's going to happen to me, and the flood is coming. Like I saw it on the news. The news broadcaster said it to me. It's happening and nobody's paying attention. Okay, well, interesting. We all didn't hear that. We don't minimize symptoms, but just when we are as family, no, we weren't watching. The newscaster was not, everybody's gonna die of the flood. Just anything outside, not appearance, again, not mood incongruence, but that something that is not true or factual that we hear or perhaps see. Okay, so that's when, again, there's gonna be drop down boxes, and it might ask you to write in, give the example they just gave. We need to see if that diminishes with treatment. Thought content, now we're looking at the delusions. Just a very fixed but false belief. Okay, paranoid, I'm being watched, I'm being followed. Someone is listening in, someone is spying. If they don't like me, they're going to poison me. They're plotting against me. Now, if you've never met this person and you are assessing them and they don't have BO, they don't stink, their appearances, not talking, they have no different affect. And they are like, I promise you, I had a phone call with this local representative and they are in my neighborhood. It's like, well, I don't know you or your neighbor. Okay. That's when we hope that a family member or somebody can be like, no, nobody's ever called our house. We've checked our phone. It's not being tapped or bugged. Like there's no sense or baseline of reality. Typically, if somebody is being brought in against their will, probably the delusional behavior, paranoia is around like, I'm going to kill myself. This is going to kill me. I know that if this phone is tapped one more time, I'm going to commit a crime or run them over. Somatic, really feeling as though bugs are all over your body. Scratching. Now, if someone has been scratching all day because they thought they had fleas, you're looking at me like, well, they do have, I have bites all, no, they don't. They've been scratching. There's no whelp or anything like that, but a delusional behavior could see the whelp, could feel the bugs crawling all over them or the itchies. Being obsessed with, I know I have HIV, and I've been tested 7 times. Okay, well, this clinic is pretty reliable. This one's pretty valid. Okay, 1 or 2 negative tests maybe, but 7 negative tests with low any type of symptom matching to HIV. Okay, maybe might be kind of marking a little delusional. Continued, out of control, a person or force is controlling your mind and your body. Others are taking over the thought or taking thoughts out of one's mind. It was there. These people took it away. Others are putting down what I have to think, or, and then most common, those ideas of reference, events that have to do with you. Like a newscaster gave me the message that our whole house is going to be wiped out. They looked at me a certain way. And I'm like, did they? That newscaster wink? No, they didn't. And told me this. We'd be able to prepare. That's kind of when some people prepare for, we've no evidence that the tornado is coming, but we're going to just stockpile and build a shelter with no tangible evidence. Form of thought, loose associations, some incomprehensible speech, perhaps mutism, no longer talking at all. We were talking yesterday, our affect has changed, we are no longer talking, or we're giving excessive detail. Okay, and we cannot do any type of goal redirection. We're just, it was green and red and purple with 12 long arms, 10 of them having fingernails and toenails, and then they're going to come through the door and kill me with their 12 toenails and fingernails and all things. Okay, wow, these are a lot of details, okay, of it, that sound like there's some inaccuracies. Our thought process. And some of these kind of start to run together a little bit. So if you're like, well, that kind of sounds, like, I don't know, that sounds a little like a delusion. Our thought process, disorders of thought that concern in which ideas and languages are formulated. Most common impaired attention, maybe poor abstraction, lack of thought content, maybe just stream of consciousness, thought broadcasting. Violence risk factors, okay, persecutory delusions, prior episode, maybe neurological deficits, not uncommon with untreated individuals, perhaps poor impulse control, paranoia, auditorial hallucinations, maybe, commands. Oftentimes the mothers are the main receptors, recipients of violence, followed by other family members. They're in my path. You're getting in my way. I got to get out of the door. I'm going to go tell all the neighbors the flood is coming. We don't need to tell people that the flood is coming. Maybe they'll find out. I have been told the flood is coming. Get out of my way. That's when people are trying to stop somebody. Maybe they're treated and people are like, you told us all the flood was coming. And that's can be, I said the flood was coming. Let's keep you contained. Let's keep you safe. Kind of increased paranoia. Well, you're out to kill me now too if you want to keep me in this house. You just want to keep me here to watch me starve to death, all the things. Homicide. Okay, this is uncommon, but assessing for, ideation. Okay, if, they don't get out of your way for the flood, what's going to be your course of action? I will get them out of my way if it means maiming them or killing them. Okay. All right. We're taking it, all right, game on. This is we're up in the game here. And then any possible predictors, okay? Previous history of violence, maybe dangerous while hospitalized, well, aggressive. Again, and then any hallucinations or delusions that have consistently involved violence. Okay, so that's going to increase it. Okay, basically an overall previous history of violence, perhaps in different settings, that have always kind of been there even without schizophrenia. Suicide, always a risk to assess. Again, it could be that a depression has been misdiagnosed and we've been given, a wrong medication, or there's a medication side effect. Up to 80%, that's pretty high, of individuals may have a major depressive episode at some point in their life. And so antidepressants, we know that can go hand in hand to combat the depression that an antipsychotic cannot combat. So a lot of times it's like, that's a lot of medication. It is. You're on an antipsychotic, you're on a mood stabilizer, you are on a low stimulant due to the ADD impulse control, and you are on an antidepressant, and some vitamin D and fish oil. You know, that's a lot. Do I need all of it? We are ruling out, because if all of this is working and everything, you know, is at bay and you're back to work, then it's working. You know, we're probably not going to take something away that's working. 20 to 50% of individuals attempt suicide. And here we say again, 10 to 13 die by suicide. And again, that could just, you know, multiple relapses, feeling helpless, feeling hopeless, lack of, you know, access to care. You know, we are so far gone. We don't know we're jumping off the Natchez Trace Parkway. We cannot see that the river is no longer there when we jump off the one, you know, I want to die. You know, that might be it, might be delusional of thinking they wouldn't die because the river's there, you know, so it could be a delusion influenced, I can fly, you know, so that can also kind of contribute to loss of life.
Are there any
Yeah.
statistics on their like a person with schizophrenia likelihood of being a victim of homicide? Like, is that increased at all, or do we just not know the numbers? Like, it hasn't been studied.
Has been a victim of homicide?
Yeah, like, but does having schizophrenia and the diagnosis increase your likelihood of becoming a victim of homicide? So, like, being a victim of domestic violence increases your likelihood of being a victim of homicide by, I forget what the number is, but it's like really high. So I didn't know if there was like a correlation with being a victim of homicide and having a diagnosis of
Like,
schizophrenia.
yes. Got it
Sorry,
now.
there was a lot of words out
Yeah,
there.
no. I get it now. Okay, so the question was, is there a likelihood of being a victim of a homicide and that's congruent with the diagnosis of schizophrenia? Yes. Yes, absolutely. If somebody is running through the streets, you know, a danger to other individuals, you know, they have escaped somewhere. Yes, they have. They could be killed by, you know, by police. If someone has a preconceived notion that Black males are erratic, okay, well, that could increase, you know, that stigma around violence associated with. But yes, we are just going to, you know, they're a danger to self and others. So yeah, absolutely, absolutely. Sensorium and cognition, you know, subtle cognitive impairments and attention, executive functioning, that working and episodic memory. Our insight is impaired, which can again have to do with non-compliance. You're crazy. I'm not taking that medication. I need to prepare for the flood. I will not go into that hospital because I have nothing wrong with me. You all are the ones that are crazy because you're not preparing and you're not telling the neighbors about this flood. You know, it's you that has bad judgment. Yeah. All right. Well, of course you would not be compliant if you think you have some sort of duty or role to fulfill that might be, you know, saving your neighborhood or the world or the planet. Other findings, again, interesting. Compulsive water drinking. I don't know why. I don't remember why this one might be. Anybody know why that increases the compulsive water drinking? You due to paranoia? Could be due to anything. I'm gonna go with that. Survey says that could be due to anything. Okay. And I found that interesting and then I didn't look it up. Differential diagnosis. Okay. So here we have the secondary psychotic disorder due to a medical condition or substance. Other psychotic disorder, schizophreniform, brief psychotic episode, schizoaffective and delusional, mood disorder with psychotic features, personality disorder, schizoaffective personality disorder. So we're going to talk about in the future. Malingering, material goal, and factitious disorder, an emotional goal. Okay, so again, if this seems like, what are we talking about? How do I flesh out if that's personality disorder, where does that fall in line? Don't worry about fleshing it out. Probably not going to go it alone. Probably going to have some assessment tools. A lot of this sometimes is just reported through a companion, caregiver, spouse, partner, community. When it comes to, yeah, they have a previous diagnosis of borderline personality disorder. Okay, all right, we're adding that to it. Doesn't mean we've got schizophreniform, but we're just adding information to previous diagnosis. Mood disorder, schizophreniform, what have you. So the course and prognosis of schizophrenia, again, all the way down to in the 5 to 10 years after the first hospitalization, 10 to 20% of individuals have a good outcome, and more than 50% have a poor outcome. This could be lack of access to care. Insurance doesn't pay for inpatient treatment or antipsychotics, or medication incompliance. I can afford to take that. I'm not going to take that anymore because I'm kind of numb. I don't feel anything. And I think I'm doing fine, right? 2 years going by, I think I'm doing fine. Let me test the waters. No. We have to do not, that's where if we are working with somebody, that's almost a do not. We're not in the business of medication do nots. This is one that's like, please do not attempt to do this alone. Call your provider. If you got somebody in your household, they can't help you either. Don't ask them to help you either. Let them know you've been considering it. Oftentimes they don't. It might be embarrassing, or they might get, how dare you? You're going to ruin our whole family. I'm fine now, well, so I'm not going to tell anybody. I'm going to do it on my own. Schizophrenia treatment. It's so complex and can be hard to treat. But we know that pharmacotherapy, medication, is the mainstay, going to be the most common. Psychosocial treatments augment the medication. Most individuals do have better outcome when it goes hand in hand. Hospitalization, and again, that's kind of how we end up okay, yeah, by way of delusional behavior, hallucinations, mentioning of suicide, homicidal, but we'll go through the ER, and then we're getting obviously a complete diagnostic evaluation as best we can get. We attempt to do medication stabilization, and then we maintain somebody there to see if the symptoms have responded. This could be 4 to 6 weeks. If insurance is going to pay for ECT, which is 3 times a week, oftentimes insurance would rather you be in the hospital so that we don't, skip treatments and we have to start all over. So oftentimes insurance is like, you know what, stay for 6 more weeks, the course of ECT under observation. And, that's hopefully going to have a better outcome due to consistency, safety, and measurement. So antipsychotics were not introduced until the 1950s, okay? And those just changed the game in treatment, right? Individuals are 2 to 4 times more likely to relapse when treated with a placebo than antipsychotics. And again, not to say that some sort of plant or anything else medicinal can help, but if there's been no link that a daffodil can help an individual with all these severe treatments, then chances are it might not help. Again, before that, that's when individuals were sometimes just put away. They are too dangerous. We don't have any treatment. The lobotomy didn't work. The shock therapy didn't work. They can't come home and be a parent, caregiver, worker, friend, community member, church member, all the things. They're just too dangerous. I mean, they're roaming around delusional, right? We see the pictures or movie, it's like The Walking Dead. I mean, we are keeping everybody contained because we don't have any place safe for them to go. We have nothing outpatient to treat any of the behavior that could be of harm to other individuals in our life. ECT, okay. Again, we know this could be beneficial in acute or chronic illness. That's not where individuals are not responding as much as they could or should to drugs. It can be difficult to access. It can be expensive. It also means that, you got to go 3 to 4 times a week. You're not going to go to work the rest of the day. Maybe on day 5, you're exhausted. Well, then it's Saturday. And if you work Monday through Friday, you're back to starting all over the next week. Kind of take off that much time of work. The same antipsychotic isn't totally doing it, but it's doing enough to where I can keep my job, stay with my family. But it's usually reserved for the severest of symptoms with the problematic behavioral issues. So it's like that they're going to be a danger to themselves or somebody else. They're going to lose their job and be homeless. This is the course of action for the most severe situation where thems are affected or somebody else is affected. The different types of therapies, one of them being psychoeducation to those if we are lucky enough that they maybe live in community, they have a family, partner, spouse, caregiver. We've got people looking out for them. Okay, so the family's on top of it, knows what to look for, manages the medication, perhaps cognitive behavioral therapy, individual psychotherapy. We talked about while we weren't recording EMDR. We would not do EMDR with somebody that was not treated for schizophrenia or was being treated for schizophrenia but was reporting any type of symptom, even though it didn't qualify for the diagnosis, because we just don't know what could happen when they go home. Are they under so much distress that they just go to bed, don't take their medication for 5 days? They don't have a support system. So we have to really be very careful with modalities that we use, which again, CBT, kind of a low risk. Someone responds to it or they don't, then we don't, I don't know how my thoughts influences my behaviors. Probably can't identify one. Okay. All right. Probably not going to be too helpful. We are going to take a break here in person. And let me come up here and I am going to, right. I'm going to share the screen. We are on slide 48 and on resources and looking at, again, NAMI has a lot of literature. They'll publish where the support groups are. Do a really good job with that, psychoeducational component. I feel like they used to run support groups. I don't remember. Schizophreniform. So here we're starting to launch into the different disorders. And this is when it gets like, oh, they all sound so different, but they all sound the same. Don't get lost in the weeds. And I'll tell you why in a minute, to be continued. It's similar to schizophrenia, but the symptoms last between 1 and 6 months. Okay, so kind of a different, timeline. Typical presentation is a very rapid onset without a significant prodrome, with return to the baseline functioning. So what your subjectively baseline functioning was within 6 months. So we're kind of looking at it kind of like a quick onset. If an individual doesn't have good prognostic features, that could be early schizophrenia. Okay, so once again, this is when we're measuring time, and it could be years, it could be months. People were like, okay, we're going on whatever somebody has self-reported, and sometimes time can be a vortex. Schizoform disorder. So the good prognostic features, onset of the psychotic symptoms within those first 4 weeks. Okay, noticeable change, unusual behavior, different level of functioning, oftentimes confusion or overall perplexity at the height of the psychotic episode. Good, pre-morbid or before this incident occurred, social and occupational functioning. Okay, we've got that support coming in. And the overall absence of blunted or flat affect so that we can see the prevalence of symptoms, considering our affect isn't blunted or flat, kind of masking it. So again, schizophreniform disorder. Okay, so here's where we start to see an overlap in treatment. So if it's like it's schizophreniform, schizophrenia, we're going to talk about delusional disorder, schizoaffective. Chances are, if it's extreme and we go through the hospital pipeline, we're going to be doing the evaluation at first. More often than not, probably some antipsychotics, followed by 3 to 6 month course of antipsychotic medication. This is going to be just really up to the person prescribing and the diagnosis that maybe collectively was agreed upon, perhaps, or a conclusion where it's like this might be less severe. It lasted a short amount of time. So we're going to do a shorter course of treatment. Okay. And very closely monitored, obviously, by the prescribing physician. Next is schizoaffective disorder. It's going to have features of both schizophrenia and affective mood disorders. Okay. We know that depressive type may be more common in older patients, maybe the bipolar features in the younger individuals, slightly higher rates in females than males. The age of onset is later in women. Men may exhibit antisocial behavior, okay, destructive, what have you, and flat or inappropriate affect. Etiology theories, again, around schizoaffective disorder, we sometimes hear it. It's a type of schizophrenia or a type of mood disorder. Sometimes we heard it being called like a type of something. Simultaneous expression of schizophrenia and mood disorder symptoms. And it's that third type of psychosis, a heterogeneous group of disorders encompassing all of the above, most likely. So again, this is going to be, we're getting information from the individual, maybe caregivers. We're just trying to catch as much as we can. Presentation of symptoms, how long they've lasted, severity, whether they're homicidal or suicidal, ideation, active, what have you, in order to basically create a treatment plan, for the course of the disorder, to keep an individual first and foremost safe, but back to baseline level of functioning. Schizoaffective disorder diagnosis. Okay, so here are these criteria. They all start to look the same. Criteria A, uninterrupted period of illness during which at some time, okay, there's either a major depressive episode, a manic episode, or mixed. Okay, we go between manic and depressive, concurrent with symptoms. Here's the my brain is spinning, that meet criteria A for schizophrenia. So we've got this criteria A, and then we've got 58 million slides ago, the criteria A for schizophrenia. Okay. And then we're just going to take that brain and go bump it up to the note here. The major depressive episode must include criterion A1, B1 Avenue, the depressed mood. Anybody know that song? No? All right, I'll stop there. All right. Here comes B, C, and D. Again, overlooking, during the same period of illness, delusions, hallucinations, at least 2 weeks, in the absence of prominent mood symptoms. Symptoms that meet criteria for mood episode are present for a substantial portion of the total duration of the active and residual periods of the illness. Disturbance is not due to direct psychological effects of a substance or a general medical condition. So we're always looking for substance-induced or medical condition-induced, or how they affect the overall affect, appearance, speech, all the things. And so if you're just like, that's a lot. How does that overlap? How do we distinguish? Trust me, my friends, all of us who've been doing this for a while can't do it. Okay. It's a treatment team approach a lot of times. Today's interview saw this, tomorrow the nurse saw that. Psychiatrist prescribed this, social worker is monitoring group behavior. It's typically a interdisciplinary approach to treatment, evaluation, and course. Speaking of course, slide 56, a chronic mental illness requiring long-term treatment. So individuals with more mood symptoms do better than those with more psychotic symptoms. Okay, because again, then we're going to pharmacologically treat the mood. Treatment is with an antipsychotic medication and a mood stabilizer, okay, for the bipolar type, and an antidepressant, plus an antipsychotic. And then we're looking at the psychosocial therapies for both. So once again, before we really, start any type of psychosocial therapy, we have got to make sure our little cocktail here, dosage, amounts, how often, frequently, we are stable. Okay. So sometimes it's like, we don't really need to measure how someone is doing because we have flatlined them with a mood stabilizer. They feel nothing. They feel numb. Got to tweak that, or they feel no treatment for the depression. So not that we can't not treat somebody, but it might not be an accurate depiction of what's going to look like when they have gotten to their baseline. Here is a case study. I'm going to skip on through that. Here we go to another disorder, delusional disorder. It's really rare that these individuals are going to be admitted to an inpatient hospital. The average age is 40 years old, slightly more in females. Females are likely to have more erotomic delusions. And then males are going to have more paranoid delusions. Thank you for that. I was going to say that 12 different ways. Etiology is unknown. We do not know because it's not related to schizophrenia or mood disorders. Like what? We're talking about schizophrenia and we're talking, not related. But the studies do show an increased rate of delusional disorder, the suspiciousness, the jealousy, and secretiveness in family members of delusional disordered patients. Okay. Once again, ruling out medical conditions that could be associated with delusions, and the Huntington's disease, cardiovascular, dementia. Again, looking at dementia that is not related to schizophrenia. Early onset dementia, sometimes we start to get a little bit paranoid. We can go into maybe delusional behavior. And then oftentimes we're ruling out schizophrenia and looking more at a diagnosis of Alzheimer's, of dementia type of not. Talk about confusing, but we'll get there. Different day. The clinical features, oftentimes the appearance is unremarkable. Maybe an individual is a little bit eccentric or odd or suspicious. When doing the mental status exam, remarkably normal, except for the delusional symptoms. But the delusions are non-bizarre, and they have been present for at least a month. The main defense mechanisms when trying to work with an individual in that preliminary state, just the overall reaction formation, possible denial, possible projection, maybe some transference. But there's multiple factors associated with the formation of delusions. Now we're all going to say that wrong for the next 10 years. So then we have the subtypes. So here's where we've heard that before. We've got the subtypes. So 3 different ones here. When you're doing your assessment, this could be another drop-down box where it's like, all right, let's look at subtypes, and you're going to check all that apply. And sometimes you're writing it in. Okay. They're having delusions that another person, maybe of high status, is in love with them. more common in females. And again, that aggressive behavior of males. The grandiose type, and this kind of can remind us a little bit of like narcissism, kind of an inflated worth, power, sense of self, identity. I'm now related to Hillary Clinton. I never told you all that, and I'm really important. I'm going to run for an office. None of that's true.
Hello.
Okay. Jealous type, the delusions that the individual's sexual partner, non-sexual partner, intimate partner, different levels, is unfaithful. Okay. Usually affects males more often than not. So just again, increased paranoia with no significant detail, tangible evidence of such, where it's kind of like, this is getting a little delusional. I heard you talking on the phone with somebody. It was my coworker. It looks like your location said you went to lunch over here with, and yeah, it was with Bill. He is the maintenance man at work. Are you sleeping with them? No. Do you like them? Are you spending extra time? Are you lying about it? You turned off your location. You don't want me to be with Bill or Michael or, Leslie or whomever. When there's really no like tangible truth. We take that, you have lunch with Bill, and turn that into a relationship. You're cheating on me, all those kinds of things. Which, if you're doing a lot of that, you may end up not being with that person.
Do that have to have a certain timeline? Because I mean, we've all been on. But like, honestly, that's half of the stuff I see on people's videos that they're talking about. They're just like, oh, you want to hang out with Cal? Okay, we have to send me a picture when you get there with them, and you have to, are you said you're going to be done at 6, but you're not done at 6, so where are you? Or, oh, you left work early, but why didn't you tell me you were on your way home and you didn't call me? What were you doing on your way home? Like, what I guess differentiates just like, I guess that type of jealousy that's not a disorder into a disorder.
When it quickly escalates into a narrative of untruth.
And it just remains consistently that way.
Yeah. Yes. And then it can become dangerous of like, you're not leaving the house because you have slept with Bill 10 times.
Oh.
I had lunch with Bill twice. You turned off your location for 2 weeks. No, a day of that, not 2 weeks. These kind of bigger and bigger. Yeah. No, I don't even know. It's gonna spout off something.
For my job, the office of safety right now, my practicing job, we do see that really often, I guess what you're saying, and like the spectrum. People have gone past clinical to clinical.
Yeah.
Insane. And literal murder.
Yeah.
Yeah.
And it's generally,
Stalking.
I see it way more often than
Mm-hmm.
but it's just saying, I mean, we sometimes see it with women as well. But I was curious, like, do people ever get better? Because I just don't see it on my side of the thing. Like,
Yeah. I mean, again, I think, where it would be, do you need a kind of an antipsychotic? Because this is spinning out of control, like episodic, to where once you're kind of stable, it's like you kind of turned into a stalker. You went overboard. You had these really big stories that were completely delusional about my whereabouts, my work environment. So I think that sometimes the hard part is it doesn't get treated because the person who's receiving that is like, I don't care what you are, but this isn't going to work. So sometimes it's like repetitive relationships where this happens. Then, and again, if they have a job, they have a family presenting, what have you, and you're seeing them maybe as a client, and you're like, if it's 6 relationships in a matter of like a year and a half, that's not a lot. Or is it a lot? We don't know. Not our circus, but we're working on interpersonal skills for relationship development or maintenance. Can you get any feedback as to why this person said it wasn't working? That's when sometimes we notice a theme of jealousy and paranoia and extreme behavior to prevent that person leaving, cheating, hurting. all the things. And it's like, whoa, okay, let me point out that we went off the grid of location one day, and then you're like, but probably was 2 weeks, and you're just taking that person down. So now we've got 2 years of a measurement of that type of behavior, which the person dating them may not stick around to really hang with it, and that can happen. Does that make sense? So it's kind of that, like, is the person that's going through it with them, like, you need major help. This is getting to be like beyond delusional. Family gets involved, and it's like, they've not been like that. Like, this is they're not the jealous type. And then it's like, oh, wow, sudden onset, age 31, getting worse.
Interesting.
Yeah.
So family and friends would probably more report like, no, I haven't, like, they would hear more stories of like, oh, my ex Jessica was just a horrible lying, cheating whore, or Sarah was over here just running around town all the time. So they wouldn't really hear like kind of that, I guess, background piece. Like, it mostly is just between the two people involved in the relationship versus like family and friends maybe aren't necessarily seeing that dynamic
Exactly.
happening.
Yes.
And I think part of it is one of the things with a delusion, besides the fact that you're doing things wildly, your preventative or reactive measures are wildly out of proportion. One of the other things to consider is there anything in your history that to you, this is not delusional? Like with a delusion, there's usually not a root of truth in it. Like, I have a reason I'm believing this thing, whereas I'm not gonna get on my soapbox, but I think the cluster C, particularly personality disorders or attachment based, I'm off my soap. But for example, like narcissism, how does it differentiate between like
This type of disorder.
this particular jealous subtype is, sorry, iPad was doing something, is like in someone with more narcissistic tendencies, there's usually a root of where that behavior came from. So maybe it's not, oh, I had someone cheat on me before, and so I'm hyper vigilant about it, a little paranoid. It could be like, I saw my parents behave this way. My mom was cheated on all the time.
19
So I'm
pounds.
like this with my dad, versus like a delusion of like, there's really no thread of truth that you could have even spun out of
So
control.
there's not like, oh, I found a text on the phone that said, hope you had a great day, and now you're dating or you're
Or like
sleeping
my
in.
best friend
Yeah.
in college
Just
randomly left
like,
me because they had someone else on the side I didn't know about. Like,
Mm-hmm.
that can be spun out of control into
Okay.
like narcissism. But with a delusion,
It's
it's
just
just
like
my
there's
opinion,
not
of,
even
like you
any
can't
kickstart.
even follow a thread
Okay.
of like where you made that change.
Okay.
No ounce of truth. Yeah.
Are these individuals, can they become violent?
Yes.
Because of these
Mhm.
delusional-
Especially if locking you in the house and putting you in a room where you cannot do anything, and I will make you stay there because I believe I'm keeping you safe with me. That's that like, whoa. Yeah, yeah. And the belief that I have to do this to you to keep you safe. That, that's kind of that, like, you believe you have to torture me. Like, that's off the
It's not about
charts.
control, it's about a fear
Mhm.
at the root of it.
That
Mhm.
makes sense.
So do you ever see, we do a dangerous assessment at all with my clients that I do training. And I was curious because I always see people repeat offenders, same man, we see the same one.
Mhm.
Or do the people ever on the other side? Because I just figure they're screwed. Or, I mean, we all meet community members too, or like friend of a friend, like, oh my God, this person's a stalker. This person
Mhm.
assaults women, and I don't see like people get better, you
Yeah.
know? Do you ever see as a clinician, people like, oh, I used to be a stalker and now I figured out that it was just rooted in trauma of like my divorce or something, and they get better with clients you're with?
I have not. I've seen, where I've kind of been like, that's borderline stalking. It is over. And if you go any further, this is the legal implication and you might lose your job. And I have seen someone be like, oh my God, I'm like, you probably won't be approved by the bar association as an attorney, if someone is like,
Mhm.
you know, like that. So sometimes when somebody can like accept like that, you know,
Almost like a bigger goal that's worth more than the delusion, if that makes sense.
yeah, or
Like
they
being
can
like-
be,
Contacting this person. all the
absolutely,
time, Like.
absolutely.
Something might trump that. So it doesn't necessarily go away, but. the
Might not
thing
go
becomes
away,
always
yes.
more
Mhm,
Motivated to that
mhm.
goal thing. when
Or
it's
they don't want to be a stalker because their character, that's like
their
not
trait.
who they, I mean, I've never been this way. I've never been this obsessive. I've never acted like this. So it's like, okay, so we know historically your behavior in relationships haven't been like this, which tells me you are aware enough that I'm challenging you to be aware of when someone gives you pushback and says, mm, I'm not gonna stay in this relationship if you're calling me over and over again. Just not, you know, that's kind of good news because we're so self-aware and we don't want to be that person. That's more like personality disorderish. If that makes sense.
Once you cross the threshold of self-awareness and wanting to be a good person and catching it versus people who are just not interested in really being
Mhm.
that and following the path there. I thought that's a really interesting line.
Yeah.
That's cool. Thank you.
Yeah. Yeah.
So I had talked to you about this back
Mhm.
in the semester. And a friend of mine actually dropped border protection.
Mm. All right. All right. We took a little break. Welcome back. I'm going to share our PowerPoint here. Derailed, slide 62. Again, delusional disorders. Okay, subtypes. So here's going to be, we've done the drop down boxes all the way in our assessment. And just going to have, again, it's going to give you the 3 and you're like, I think that, you know, it might be mixed type. They have all of the above, you know, or unspecified type. Sometimes it'll have you just write down if it's like doesn't meet criteria, you'll still specify. The course and the prognosis. So again, we kind of talked a little bit about this. Looks a little bit different than schizophrenia. So I'm not going to go through it. Read it on your own. Delusional disorder. Okay. It can be really difficult to treat. Again, introducing antipsychotic. Although, you know, if somebody, you know, wants to be resistant, there's not any other prominent behaviors, it might not help. Again, psychotherapy, you know, to kind of confront somebody, you know, want to have, obviously trust rapport has to be established. And someone might not be willing to give up the delusional behavior because it's keeping somebody in their relationship. And there's no need to, you know, there's no report to be made, no DCS, there's no child. So again, sometimes we have the opportunity to kind of, you know, point out like interpersonal, you know, it doesn't sound like, sometimes I'll just say, it doesn't sound like that behavior is working for that person. It might work for you, but a lot of times when that behavior doesn't work for another person, they leave the relationship. You're not going to leave because your own behavior, but that behavior, you know, just keep in mind that that might not work for the next 3 months if you act like that. You know, here is, we're looking at 28-year-old female from Central America brought to the ER after an accident in which she witnessed the death of her 9-year-old son. Shouting, she's confused, fearful, appears to be hearing voices. There's no apparent physical injuries except for minor abrasions and bruises. And so again, we're trying to decide, you know, what is the provisional diagnosis. Now, this is so simplified. We'd be getting more to the story. We'd be asking where the crime scene was. Obviously, if the crime scene changed or the details changed, it might be, okay, that's a little bit delusional, or we get a history that they have schizophrenia, they've come before, what have you. And again, brief psychotic disorder episode. So again, this to me, when I read it, I'm like, that's really hard because if someone's screaming, shouting, confused after witnessing the death of their shot, rightfully so. And then of course, keeping in mind the cultural context of someone being from Central America. How might that present? I'm not familiar with their culture and trauma. Okay, well, I need to pump the brakes a little bit, pump everybody else's brakes, and have we considered norms, behaviors that are maybe a reaction that are not related to psychotic disorders. Brief psychotic disorder, uncommon, occurs more often in younger patients. There's a higher incidence in women and individuals in developing countries, particularly those who have experienced some sort of disaster or major cultural change. So again, kind of going back to immigrating maybe quickly and having to assimilate quickly. That can cause lack of sleep. I mean, all the things that, again, you may be paranoid of what's going to happen. Will you be sent back? Will your children be taken from you? You heard something that they were, the rumor starts, the obsession starts. We kind of start to slip into, okay, we're looking at a little bit something different because there's no basis of truth to that. This also goes sometimes with personality disorders. We're going to be talking a little bit more about that when we get to module 10. Again, here is the diagnosis. So we're looking at the symptoms here, one or more of the following. And again, as we're going through this, it's like, golly, this sounds like slide 12 and 19 and 24. And yes. So if it's kind of like, I can't distinguish this from, a hole in my head. Well, absolutely. It can be really hard, which again is why it's a lot of times interdisciplinary. And again, we as social workers are oftentimes the ones that are going to assess or evaluate for a culturally sanctioned response pattern. Okay, a pattern. Okay, and so again, due to culture, race, ethnicity, spirituality, what have you. Continued, the duration of an episode, again, where we start to go, oh my gosh, at least one day, less than a month, here we go, at least this, less than that, no more than. And then again, not accounting, the disturbance is not better accounted for by a mood disorder with psychotic features. Here's where my head starts swirling. And then all the below, schizoaffective, schizophrenia, and then physiological effects of substances, general medical condition. There goes back to PowerPoint 1 and the specifiers. So we're going to specify with marked, stress, without marked stressor. And then here's the postpartum onset. I'm excited to talk about that. Brief psychotic disorder. Again, we're just traveling on down the chain of they sound alike. Here we talk about the clinical features, have some, memory impairment here, the prognosis and the course, good prognostic features indicating a high likelihood of recovery, that pre-morbid adjustment, few pre-morbid schizoid traits. We're going to be talking about that with personality disorders. Severe precipitating stressor, something going on in their life that's very stressful, even crisis. Sudden onset of symptoms, we can catch it. There's a difference in how a person was a couple of days ago, maybe confusion. Again, they come through the ER, you're assessing them, 30 minutes in is not enough time. So a lot of times we're just specifying whatever we can match with, I'm going to write that down. I don't know where it falls. That's okay. Think people are, think everybody's cheating on them, what have you. Maybe they are, maybe they aren't, but everybody, how many people are everybody? Really? All that many people? So again, where hospitalization could be needed for evaluation and just protecting the individual from themselves or another individual. the introduction of antipsychotics and benzos could be needed until they are recovered. Then, of course, psychotherapy. Okay, coping, psychoeducational, and again, family therapy, maybe individual therapy. It could be partner, therapy, what have you, just in order to keep an individual as safe as possible, in addition to those that they possibly living with, what have you. Other psychotic disorder. So we just have this like other psychotic disorder, psychotic symptomology. Okay, we're just noting all of it, but there's inadequate information for a specific diagnosis, or where there is contradictory information, or disorders with psychotic symptoms that do not meet the criteria for any other psychotic disorder. So here we are, we have a map. It leads us to nowhere except for other psychotic disorder. Bam, bam, bam. But we have got to, this is severe enough, but this is contradictory, mentioning of hopelessness, helplessness, potential suicide. Oftentimes this is by way of hospitalization. This could be outpatient, assessing a client for the first time. Again, looking for severity. Can they stay safe without hospitalization? All right. Other psychotic disorders. Postpartum psychosis does not meet criteria for mood disorder with psychotic features. A psychotic disorder due to a general medical condition or any substance-induced psychotic disorder. Those psychotic symptoms have lasted for less than a month, but not yet have remitted. So that's where we look at meeting criteria for brief psychotic disorder. Where the criteria is not met, for brief psychotic disorder. Perhaps persistent auditory hallucinations in the absence of any other feature, a shared psychotic disorder. So something that, nobody ever really talked to me about postpartum psychosis, lack of sleep, screaming baby 4 days in a row, milk going everywhere, other kids running around. Your mind might play a little trick or two on you. Maybe coupled with depression or anxiety. And so again, long time ago, it might be gonna knock you out with some Valium. That doesn't help it because you get sleep and a break, then gonna put you away for a little while. Baby can't go with you. Going back to postpartum psychosis, again, we're evaluating, really the safety of a newborn baby and the caregiver, parent, what have you. The hard part about sending somebody to the hospital, it feels really, sometimes the ethical dilemma is the baby cannot come. So it's like, God, we're about to put that breastfeeding on hold. We're about to that attachment, all of it on hold. How traumatic is that going to be? When they don't really want to hurt their baby, but delusionally be better off without the baby. That can be really hard. So oftentimes is there a support system that can stay with them till we go to the psychiatrist the next day? What does it look like to maintain their safety at home? And really that, knowing that you're going to have to pick probably baby, safety, if that safety is jeopardized. Other psychotic disorders, again, those persistent non-bizarre delusions, overlapping mood episodes, and again, the report of being present for a substantial portion of time. Situations in which the clinician has concluded that a psychotic disorder is present, but we are back to unable to determine whether it's primary, general medical condition, or substance-induced. Postpartum psychosis, just the statistics on this, 50 to 60% have just had their first child. So they do not know is this normal? I'm supposed to have lack of sleep. Yeah, but 5 days is kind of a long time. Kind of the obsessions around like no one can keep the baby safe but me. I mean, Yeah, but other people can help hold the baby's in danger and things like that. 50% of children have experienced perinatal complications postpartum psychosis. And then again, 2/3 of the individuals go on to meet criteria for a mood episode. And again, it's considered a psychiatric emergency, so with a statistic still high, 5% dying by suicide or 4% committing infanticide. So again, if we have any doubt, let's go to the hospital, and again, we have a good relationship. We've watched this person. We know they have a mood disorder. Okay. We know they have gone untreated pharmacologically, their mood disorder from months 1 to 4, felt better because sometimes hormones are a protective, carried on through the pregnancy. So we've got that going. Okay. Is that a manic episode? Lack of sleep? Is that psychosis? Are we at danger? Someone tells you that their caregiver isn't there. It can be really hard to manage reports. I've got to call your emergency contact. We have that in our paperwork. We call, hopefully that person comes. If they don't have an emergency contact, or it's, you have to check those forms. But if it's false, we call mobile crisis. It's horrible, and the baby typically goes with mobile crisis. Then if there's no support system, DCS gets involved, right? And that's a whole other bag of, now we have this system involved. So we do our best to treat on an outpatient level, but the severity, it's the safety, of all individuals who are at risk.
For people that do commit,
Mm-hmm.
what do you recommend as like talking to them? Like when they come and see you, if they do come and see you for services, assuming you hadn't seen them for like you weren't part of the actual, like what led up to everything. So they're seeing you after everything.
Mm-hmm.
Like, how do you recommend interacting with those people? Because like I had a client where this is my first time meeting her. I was trying to figure out a care plan, didn't know anything. And she was older, so also taking in the context of the time frame of society.
Mm-hmm.
But I mean, she told me, she was just like, I killed my baby.
Mm-hmm.
And I was like, I'm so sorry to hear that. Like,
Mhm.
we all make choices, and unfortunately, they aren't always the best ones, but that doesn't mean we're bad people. Like, I was just kind of on the fly. Like, I didn't know what I was
Sure.
doing.
Yeah.
So I don't know if you have any like pointers, like if somebody comes to you with something like that, is there, I know there's no specific, like, yes, you do A, B, and C, and that's just
Sure.
great, but is there any sort of approach or suggested recommendation or anything like that? Because like, that's a pretty hard-hitting thing to be told. if we deal with
Absolutely.
it. So-
Absolutely. Yeah. Advice on if you're working with someone that comes to you and reports the death of their child at their own hands. I think that there's no like legal, like they're not under, they're just, so if nobody told you that before, right? They're not, if they tell you that, I think it's just that strengths-based perspective of like,
You're here, you
oh my gosh, thank you for that vulnerability. That, how did it feel to tell me that? What does that look like? What support do you need from me? Because sometimes that might not be what we're focusing on. We might think we want to process, what that looked like. But again, that's that empowerment of, you told me that, is that part of our processing, things like that. And we can go as slowly as you'd like. You can tell me as much as you want, but obviously it meant enough to say it out loud. So I sometimes just start with gratitude when people tell me things that they've done that societally are not accepted. I never had that experience before, but
I would
I can imagine it was hard. Yeah, absolutely.
Wasn't the hearing, and maybe that's
Mhm.
maybe desensitized, I'll check it later, but.
No, but yeah,
It was more just like, how do I make sure this person doesn't shame spiral?
Right.
Because they just told a complete stranger, probably one of, if not the most horrific thing that has ever happened to them.
Mhm.
And like, like my picture, like,
Yeah,
so I did just try to like validate her, like, thank you so much for sharing that with me. I know that couldn't have been
Mhm.
easy,
Mhm.
and I'm not here to judge you, I'm here to support you, like,
yeah,
it just, she kept cycling back to it, and I
Yeah.
couldn't figure out, like, is it something I'm saying, is it something I'm doing, like, am I encouraging this or like continuing to add to her shame? Like, I just couldn't figure out like, if it was just, she just needed to do that for her own well-being, or if, like she was like feeding off of something I was doing.
Sure.
So I was like, maybe I just messed something up, which is possible. I'm a human being.
Yeah.
But just wanted to ask if there was maybe like a little trick of the trade or something. 'Cause
Mhm.
everybody's individual, but some things are consistent across things.
Sometimes I will ask, and for me, when someone discloses that they have sexually abused a child and they were a minor, so treatment looked different, incarceration was not, that looked different. Now they're a grown person, they're fearing doing it to their child. So they say that, like, we've been working together, but okay, wow, that was a very brave thing to tell me. And again, you can tell me as much as you would like. And then with that individual, I said, I am so open to feedback. If I ask anything that seems voyeuristic or not, I don't know if I use inappropriately curious, but doesn't have to do with the story. Because I was trying to show like, well, that's my worst fear to my kid, yeah, absolutely. Because internally we might be like, oh, I don't know, how will this skew my objectivity? It's working a lot consultation, but just saying, I welcome your honesty. Because I could ask something that I think is a, question around, and it might be like, that seems really judgy and assuming that I wanted to kill myself or something, like that. And it's like, oh my gosh, I was not very sorry. Thanks for giving that feedback, but kind of like,
Mhm.
you want to stop, let's stop. Just again, them controlling the narrative, especially when it brings up, if we were a child survivor, that could be. And then again, sometimes it's a privilege to transfer a client. But if we're going to do more harm, sometimes that cannot happen, that we can transfer them. So we are just doing our best. And then sometimes it's saying, I'm not equipped. I don't know enough about it to be the best support for you. That can feel like, why are you grossed out? I mean, no, I just don't think I know enough. You're trying to reassure them that they just dropped this bomb, that you're not like, how do we move forward? If
It's
that
not
makes
them, it's
sense.
just schools, the skills and tools.
Sure.
To best support you, and I don't want to make a
Mhm.
misstep trying to support you that's gonna further harm you.
Yep.
We're
Yeah.
falling on this so fast. I got you on that. Okay.
Yeah. Really hard. Good question. Again, postpartum psychosis, clinical features, again, that 2 to 3 window after delivery, and then all the symptoms. Because here we are. I'm so tired. I'm feeling really restless. I'm crying. I'm super suspicious about who can be around my baby. Are they going to give them germs? Are they going to maybe try to kidnap them? Okay. Is there a history of kidnapping with this individual? Maybe some confusion, some irrational statements, that obsessiveness around baby's health, and maybe having some delusional statements, behaviors, hallucinations. What women, it's real scary and hard to say out loud is when they're like, I don't love the baby. I don't feel attached at all. I don't think I want the baby. And in like a really dark place, think about harming babies, baby be gone and be better off. Okay. All right. And that's, again, thank you so much for that information, because the more truth I have in the information, the more we can care for that baby. If the individual is saying these things and they are sobbing and they are saying like, I know I wouldn't do, I feel horrible saying it. Sometimes that makes me feel a little bit more comforted, because it's like the affect is matching, like their sadness and disbelief is matching. It's almost a protective factor, if you will, I guess, versus kind of like a flat affect where it's like, oh, we're not having any reaction to that. And that can be super harmful. I think, personal professional opinion, such an amazing internship for a social worker would be at a pediatric office. Because they hand you a piece of paper. Do you want to have thoughts of killing yourself or your baby? Do you want to burn them? I'm like, no, am I lonely? Yeah. Am Am I not sleeping? Yeah. Am I a little overprotective and paranoid about germs? Yeah. You know, but was somebody gonna ask me about it? No. You don't score a 19 out of 1 on the Richter scale. Thank you for that. We're gonna put it in your file. Okay. Versus if we had someone going over that, while your baby's being cared for by the nurse and the doctor, we're gonna care for you. You don't go back to the OBGYN sometimes ever. You're supposed to go 6 weeks, 2 weeks after a C-section. The OBGYN is not going to, they're not going to call you. Pediatricians call about baby. Nobody's calling about the one that gave birth. I just think that'd be a great internship.
We're seeing a lot more pediatric specific and postpartum specific social workers.
Mm-hmm.
There's a lot of jobs open there right now.
Yeah.
I'm applying to a few.
Yeah.
I'm applying. But we're seeing a lot more of that, and I'm so glad that we are,
Mm-hmm.
because I'd probably be a lot less fucked up if someone had said that to my mother.
Mhm.
My family would be a lot less fucked up if somebody had said that to my sister-in-law.
Yeah.
I'd love for people to be a lot less fucked up because we actually give a shit about the person that incubated and birthed the child.
Yeah. Yeah.
Not that I don't want us to be
I know.
caring for the child as well. I think it's
Sure.
very important that they're getting the care that they need. It's not
But
pie.
it's
We're not
like
taking
having
away,
like,
we're not
have
taking
like a
away
built-in
from the
here.
resources of the children by giving to the mother, but also the mother is a human being.
Mhm.
Not just a little incubating cage. Otherwise, we just treat them like chickens and put them under a little incubator.
Laying in an incubator kind of sounds
Pretty
nice.
Honestly, I could deal with a good little incubation.
Well, incubation.
I was actually talking to a friend of mine who does research over at Vanderbilt, and she said a big conversation now within the medical community is having social workers
Mm-hmm.
in clinics over
Yep.
there.
Mm-hmm. Yeah.
We may not have the best reputation, but I'm pretty sure doctors have it worse than us. So-
Yeah. And everybody has a role to play. You know, a nurse, again, it's one of those things too. The nurses are like, the piece of paper, well, I got to do how you feed, how you car seat, how you blanket, how you know, they also have a cleft palate. They cannot drink from the breast. Like they just that medical, that's, you know, we got to keep the baby alive, nutrition, you know, all the things that it's like, we cannot do a window shop assessment. You know,
And it
again,
shouldn't be the doctor's job
Mm-mm.
to be assessing those things that are not their specialty. Yes, assess the health of the baby. That is your thing. I could not sit there and tell you, I know a lot about the liver. I am not a liver doctor.
yeah,
If you come into me for therapy and you start telling me about your liver, I'm gonna tell you to see a doctor.
sure.
I
Well, and if
love
somebody's
for the infrastructure
crying,
in the doctor's
Normal
shoes
response.
to be able to say, here is someone for that.
Yeah.
To take some weight off, because that's burnout for one, and it creates a lot of issues of unintentional malpractice.
yeah,
Or I'm like, please, for the love of God, do not go to your primary if you have an option for your mental health meds. And I also recognize that that's the only place some people can get them, and I hate that. So I.
well, and also can get you in quickly, you know, so that's the other thing too.
And
It's like,
also
well,
the
if you can get in
payment for
quickly.
your insurance.
Yeah,
You might be paying buku to go
Mhm.
see a mental health nurse practitioner.
yeah,
Which is like the next most
Mhm.
successful step. So I'm loving that we're expanding this infrastructure. I would love to
absolutely.
see more of that.
And if,
Unfortunately, Jacob's gone now. So
if
he needs to go
only-
advocate for us.
exactly. And if only two, you know, when I lived over in London, I mean, social workers went to the house. You went on foot to the house. You know, somebody kind of showed up and met me in my living room. You know, come on in, have a seat. Don't touch my kid. All right. Don't go in my kitchen. Again, treatment, you know, hospitalization, medication, post-stabilization, you know, kind of talking through it, warning signs, what's your support, high rates of recovery, you know, early intervention, tons of support groups out there, tons of free support groups. Now we are, you know, telehealth, hop online, you can feed your baby and nobody see it, right? Like, you know, I used to be super paranoid about breastfeeding in public. I just would avoid everything because I don't know. What if my milk spewed everywhere? Who knows? So probably wasn't gonna go to a group, hop online and do that. Looks a lot different. Secondary psychotic disorders. Again, here we go with A through D of just assessing. Someone presents, here, just the prominent hallucinations and delusions. Okay, so fleshing out. Trying to get us through this. Secondary psychotic, substance induced. Not gonna read all the way through it. This is sort of an overlap. I wanted to get to substance induced. Okay, so criteria A, developed during or within a month of substance intoxication or withdrawal. Medication use is etiologically related to the disturbance. There's no other reason, there's no other better accounted for a psychotic disorder that's not substance induced. And then again, oftentimes, you know, that's part of the, when you wean down, what do you call it? Detox. You know, because it is like you could have a psychotic episode, you know, so that's what we safely detox, especially if perhaps you have a history of mood disorder or one of this, you know, that might be helping keep it at bay. Substance is going to have to get out of your body in order for us to see if the antipsychotic or what happens it's gonna work. We're just gonna differential diagnosis, secondary treatment. Here's what catatonia looks like on slide 83. More about catatonia. That's basically it. So I'm going to sign off with our online. Thank you for watching this far. See you soon.